Hi, this is Brian Kim. I want to share with you a case of a patient with a dislocated IOL, and I performed a Yamane technique. My Yamane technique, everything looked great. His surgery looked beautiful, but he would come in with repeated episodes of optic capture, meaning the pupil was capturing the IOL optic, and so I'd have to dilate him and do all these maneuvers. And I was just really frustrated because I felt like the surgery was executed perfectly, yet he was having these troubles. So we discussed it again in length, and we decided we're going to take this lens out and then place a new lens, but instead of placing it 2.5 millimeters posterior to the limbus, we're going to place it about 3 millimeters posterior to the limbus. You can see this is the eye. The lens is well centered. The surgery looks beautiful. And you can see I'm going to stab the conjunctiva and sclera with the needle. And you can see the orientation and position of the haptics through the sclera are absolutely perfect and nice and symmetrical. But again, this patient got repeated episodes of pupil capture of the optic. Using that needle, you're able to kind of grasp the flange and pop it up. The right side was a little bit easier, but the left side actually took quite a bit of effort, which just shows you and illustrates the point that these haptics bury nice and deep inside the scleral tissue, especially if you have a nice scleral tunnel. So again, I have not had any issues with extrusion, infection, any of those potential complications, again, because I stay nice and flat and because I make a small flange. And again, with the AR40 lens, with the PMMA haptics, they tend to be very thin and small. And you see this picture, perfect execution of the lens. But again, obviously this patient continued to have trouble. I'm aiming about 3 millimeters posterior to the limbus here, and I'm going to make my marks. Again, just a little bit back. On the right side and then the left side, I'm finding 180 degrees apart with this cannula inking the limbus. And then again, indenting about 3 millimeters posterior to the limbus and then 2 millimeters adjacent. And again, this patient's a high myope, which might explain why he has quite a bit of trampolining of the iris and it's capturing the optic. And so that's why I'm aiming 3 millimeters in this high myope. And I feel very comfortable doing that because he is a high myope. And so the pars plana is probably going to be a little bit further back from the limbus anyway, so I feel pretty confident that it'll be just fine. These are my incisions to take the lens out, and then the contralateral limbal incision to externalize the leading haptic, and then the AC maintainer. Such a shame, a perfectly executed surgery, and yet I'm having to take this lens out. This is a 3 millimeter blade. I make a vertical groove, tunnel through the cornea, and then I enter. Cut the flange on the left side. Using smooth microforceps to pull the haptic into the eye and then into the angle. Doing the same thing on the right side, cutting the flange, and then using 2 forceps to grasp the optic and then the right side haptic, popping that haptic into the anterior chamber, and then using the IOL holders in my left hand, I'm going to cut the lens. I like to cut it in that position with the haptic on right side just to the right of my cut so that the right side piece, the haptic will prolapse on itself when it comes out. So I'm always strategically cutting in a certain orientation and position to do that. So I'm going to Pac-Man the lens out, popping the right side piece up in outside of the eye and rotating the lens so I can pull out the other half. By doing it this way, the haptic collapses on itself, and you don't have to worry about the haptic scraping the cornea and damaging it. All right, there you go. Placing the 22 gauge thin-walled AEC maintainer with Epsilon. Again, I don't have any financial interests. This is a 25 gauge needle with BSS on a syringe. Bending the needle so that the bevel is facing to the right. This is the right side needle, bending it 9 millimeters from the tip with the bevel facing the main incision. And this is the left side needle, again with BSS, bending it so that the bevel faces towards the contralateral limbal incision. This is the emerald cartridge, injecting cohesive viscoelastic through the barrel and on the platform. Placing the Sensor AR40 lens on the platform, making sure that the optic is seated before bending the wings, making sure that the optic bends backwards. The leading haptic comes out straight through the barrel and the trailing haptic outside through the back. Placing it onto the injector, making sure that the trailing haptic is up and away from the barrel. Plunger as I advance the plunger. See here there? Sweep. Sweep that trailing haptic up. You have to do that, otherwise you'll damage it. And then advance the plunger. We're ready to go. This is a 25 gauge needle, placing it through the contralateral limbal incision. Placing the injector through the main incision, making sure both bevels face each other. By doing it this way, the leading haptic will externalize and be fairly parallel to the needle, docking the haptic on the bevel of the needle. As my assistant advances the lens, more of that haptic is internalized into the needle. I withdraw the needle and the haptic comes out passively. Deliver the optic and the trailing haptic. Pushing some dispersive viscoelastic to protect the cornea more, pushing the optic back as well. Pulling some of the leading haptic out more, which pushes the optic away from me, which again gives me more room to work with for the trailing haptic. Stabbing the conjunctiva and sclera at the first mark, staying nice and flat, tunneling 2 millimeters and diving down, making sure I have infusion on as I do this, so I have a nice firm globe. Using some smooth forceps to slide towards the left, docking the haptic on the bevel of the needle. 2 pushes and then I'm done. Disengaging the needle from the syringe. Internalizing the leading haptic and placing it into the angle. And then doing the same thing on the left side. I'm going to hold the eye with the contralateral fixation with the forceps. Stabbing the conjunctiva and sclera at the first mark with the needle. Tunneling 2 millimeters, staying nice and flat. Feeling the resistance of the needle through the sclera, which ensures I have nice scleral support. Making sure the eye is firm, as usual, as I stab, and then I dive down. You have to stay nice and flat. You got to feel the resistance of the needle through the sclera to make sure that the haptic has great scleral support, and this prevents that dreaded flagpole sign. Turning the needle to face the haptic, dock the haptic on the bevel of the needle, 2 pushes, and then I'm in. Withdrawing both needles just a little bit, pulling the left side needle all the way out, limiting how much haptic comes out, drying the tip, and then cauterizing it to create the flange. You see a nice flat position of the haptic, flat to the sclera, which means I have a very good scleral support of the lens, which most and best approximates an in-the-bag IOL placement. Withdrawing the right side needle, making sure I limit how much haptic comes out, drying the surface, drying the tip, and then cauterizing it. Again, nice flat position of both haptics, which will best approximate an in-the-bag IOL placement. Pushing both haptics flush to the sclera, the flange, and then reapproximating the conjunctiva. suturing the main incision. You can see very well executed surgery. Lens is well centered, and again, I'm confident of the support of the lens, scleral support of the haptics. Remember, centration is not as important with this technique. What really matters is that scleral support. Even if it's a little decentered, it doesn't matter because the optic is bigger than the pupil. But having that scleral support to best approximate an in-the-bag IOL placement is so important. Remember, a flagpole sign is really bad because it can increase your risk for extrusion. The lens will tilt backwards. The haptics, the flange can be exposed. So I take the AC maintainer out and hydrate my incisions, and that's the end of the case. So again, this patient had a dislocated lens. I performed my Yamane technique. Everything looked great, but he came in with pupil capture of the optic on numerous occasions. He did not want to have another surgery, but because he kept having these problems, we had a long discussion, decided we're going to take the lens out. And again, it was a shame because it was really executed perfectly. In the lens, you saw the haptics are perfectly symmetrical in good position, but we aimed 3 millimeters back this time, and we put the lens in, executed it just as I do. Again, externalizing the leading haptic through a contralateral limbal incision, making sure I'm nice and flat with my penetration of the needle through the sclera. And I'm happy to report that this patient did very well. The pupil capture of the optic stopped. His vision actually improved as well, and he was very happy. So I hope this was helpful to you, and I thank you for your attention.